Hello, welcome to today's presentation, Endovascular Treatments for Stroke, Advancing Rapid Care, presented by Dr. Daniel Raper, neurosurgeon with UCSF and Washington Health. Dr. Raper is an assistant professor of neurological surgery and radiology at the University of California, San Francisco, and a consultant neurosurgeon and neurointerventional surgeon at Washington Health. Dr. Raper earned his medical degree from the University of Sydney School of Medicine. He completed a residency in neurosurgery and a fellowship in neuroendovascular surgery at the University of Virginia, and a second fellowship in cerebrovascular surgery at UCSF. He has an active subspecialty practice focused on complex cerebrovascular pathologies with a special interest in multimodality and innovative treatment approaches. Please welcome Dr. Raper.
Thank you very much for giving me the opportunity to talk to you today. I'm going to talk to you about endovascular treatments for stroke, and I'll talk a little bit about what that means. But let's start off with some basics. What is stroke and why is it important? So this is some data from the American Stroke Association and stroke.org, which are some really great resources just for anyone who's interested in learning about stroke to understand the impact and the scale of this problem. So let's look at some numbers. About 795,000 Americans will have a new or recurrent stroke this year. Stroke is the number 5 cause of death in the United States, killing more than 140,000 people. 1 in 19 deaths is related to stroke. And more than 690,000 people are going to have a stroke which is related to a blood clot, which is called an ischemic stroke, which cuts off some part of the blood flow to the brain. So this is sort of a cartoon of what that looks like. A blood clot is sitting here in the blood vessel in the brain, and it's stopping the blood flowing into the distal part of the territory of the blood vessel, stopping the brain getting its normal blood supply, and is called an acute ischemic stroke. As you can imagine, we have a saying that says time is brain, and if you can get treatment quickly, you can have less damage to the brain. This really underscores the importance of getting to the hospital quickly and recognizing when a stroke is occurring. And so one of the messages that we always tell people is spot a stroke fast. You may have heard this mnemonic before, but it's super important and kind of easy to remember if you keep it in mind. Learn the warning signs for stroke: face drooping, arm weakness, speech difficulty, and if you see any of those, it's time to call 911. If you get to the hospital fast at the first sign of a stroke, you can be evaluated and potentially treated with medications that can be more effective if they're given earlier. One of these is called a clot-busting medication, which is administered through an IV, but that has to be given within 4.5 hours from the last known normal time. And the other potential intervention that we can do for acute ischemic stroke is mechanical thrombectomy, which means endovascular treatment to take the blood clot out. And we can do that in some patients up to 24 hours after a stroke, depending on certain inclusion and exclusions that make a patient eligible. And we're going to talk a little bit more about this procedure today, but I'd like to illustrate it by going through an actual case. What you can see here on this CT scan, the patient's eyes are at the top, the back of the head is at the bottom. Our images are always flipped around just to make it harder on you. But the left side of the image is the right side of the patient, and the right side of the image is the left side of the patient. So the patient is having right-sided weakness. That means the left side of the brain is affected by a stroke. And here we can see part of a blood vessel that supplies that area. And there's an area where it's a little bit bright, which gives us a clue that there might be a clot sitting there in that blood vessel that we might need to address. So we need to know some information so we can assess whether or not it's going to be a safe and effective procedure to try and take that blood clot out from the inside. We need to know something called baseline functional status. So that is, what's the patient like when they're normal at home? Are they able to take care of themselves independently, or do they have assistance for their activities of daily living that they require from other conditions that they have, medical conditions or frailty or any number of issues. And we know that if patients have a high level of existing disability before having a major stroke, the risks associated with intervening go way up. So we have to know that beforehand. Something else I mentioned is time since last known well. What we want to know here is how long has this stroke been potentially going on for? And is there an area of brain that is still tenable, that it has a penumbra? That means that there's some reduced blood flow, but the ability for the brain to recover that we can save by doing an intervention. And generally, as we mentioned on the last slide, up to 24 hours is the time frame that we can consider intervening with an endovascular treatment. The final thing that we need to assess when a patient comes to the emergency room is the severity. This is done using a scale called the NIH stroke scale, and it's a systematic way of assessing what are the deficits or problems that a patient has related to a stroke. So after we get the initial scan, then we want to look at the blood vessels. So here you can see two ways of looking at the blood vessels from our same patient. And an easy way to look at this is to compare one side of the brain to the other side of the brain and see if there are any differences. Here on the patient's right side, there are all these blood vessels. And on the left side, there's one blood vessel going out, and then it kind of cuts off. And you can see that here on the other way of looking at it, from the top to the bottom. On this side, the blood vessel cuts off suddenly, and that's what we call a large vessel occlusion stroke. The next piece of information that we want to know is how much area or volume of brain is there potentially to save from doing a procedure. And so we have now something called a rapid app that we have on our phones. It uses AI to help us understand the amount of core infarct and penumbra, together which enables us to see the risk and benefit of intervening. And then we have a protocol for assessing patients who have this kind of a problem, which we go and we follow down and say, is this patient suitable to receive medication? Is this patient suitable to receive an endovascular treatment? And we go on, every patient goes through the same algorithm so that we make sure we can give everyone the best quality care that we can. So in this case, the patient had a penumbra or salvageable brain, had a large vessel occlusion, and he presented in the time frame that would enable us to do a procedure, and so we took him for a thrombectomy. So an endovascular thrombectomy just means taking the clot out. Endovascular means through the blood vessel. So what we're going to do is we're going to first take some pictures. So we inject contrast, which is the dark material that you can see, which outlines the blood vessel. And here you can see this is a left-sided injection, and there's a cutoff of contrast where no contrast is getting through past the blockage in the blood vessel. And we're looking at it front on here and side on here, and usually all of this area is filled with blood vessels and nothing is here because of the blood clot. So we're going to try and take the blood clot out. So how do we do it? We use a device called a stent retriever or a stent retriever. You can see this is a metal device which goes into the blood vessel, engages with the clot, and then we pull it out. It doesn't stay in the blood vessel. It kind of looks like a stent, which is a metal tube that you may have heard about, which keeps blood vessels open. People get them in their heart all the time. But this is a temporary device, and our main use of it is to engage the clot, as I said, so we can pull it out. And it looks something like this, where it will go into the blood vessel, and then here it is all interspersed with the clot, and then we're going to pull it out. We use some other important equipment to help us with that, make that successful. We use a catheter, which is a plastic tube with a balloon on it, to reverse the blood flow so that the blood flows back towards us so that we can be more successful in taking the clot out. And different types of catheters with specific designs to go all the way up to the face of the clot to help engage the clot, and we put that onto a suction to try and help suck the clot out as well as pull it out with the stent retriever. So we use all these different techniques to try and stop the clot from breaking apart, enable the clot to come out, and our real goal is to restore full blood flow to the area as quickly as possible. So I'm going to show you here a little bit of a graphic picture, which is actually the blood clot. So here is the blood clot from the canister of the suction device. These are the tiny little pieces of clot that come out from a small blood vessel in the brain, and that can make a huge difference to the patient. And after we do that, we take more pictures, and you may be able to appreciate the difference here. Before there was a complete block off there, and now all of the blood vessels supplying the brain have come back to life. And here again, just to illustrate that for you, this is what it looks like before, nothing here, and after, all of the blood supply to that area is restored. So really that gives us the best chance of restoring functional movement in the limbs and speech for the patients who have deficits related to this occlusion of blood flow. And what happened to this patient afterwards? Well, he went to the ICU. We take very good care to control the blood pressure a certain way to make sure that his blood pressure doesn't go too high or too low. And he gets a series of medications that are shown to reduce recurrent stroke. And you know, he has to go through certain evaluations by the physical therapists and the speech therapists. And we evaluate his stroke scale on every day that he's in the hospital. And you can see over the next 3 days, it completely went down almost to zero. Zero means completely normal, and he was able to go home. So let's just spend a couple of minutes looking at, you know, some of the work that people have done to try and understand how this helps people. And this is a very busy slide, which you definitely don't need to know the details of, but it outlines some of the major advances and trials in stroke research related to intervention, you know, over the past 20, 30 years. But the real turning point happened in 2015, 10 years ago, when a number of very important, well-conducted, multi-center trials demonstrated that this approach, taking the blood clot out from inside the blood vessel, definitively helps people get better when they have this type of large vessel occlusion stroke. And I'd like to summarize this for you here. These major stroke trials, which were published in between 2015 and 2018, and even some more recent ones as well, showed us that endovascular treatment leads to significantly lower disability at 90 days for people who have a large vessel occlusion stroke. The number needed to treat is 2.6. Now that means that if you treat 2.6 people with an endovascular treatment, you can restore functional independence to one person. This is one of the most effective medical interventions that we have ever had. If you think about very effective medications like statins for cholesterol or blood pressure medications, the number needed to treat for a very, very effective medication is in the 20s or 30s. But here 2.6 is incredible. Patients benefit from thrombectomy up to 24 hours from the last known well, as long as the imaging suggests that there is an area of brain that can help, that can be restored, called a salvageable penumbra. And patients with larger established stroke, which is called a large core, also benefit from endovascular treatment. Even if there's an area of the brain that's already been affected by the stroke, we know that people actually have better outcomes if we can restore their blood flow. So patients with a larger clot benefit from endovascular treatment. And we have high success rates. We are able to restore blood flow most of the time, and we have a grading scale to tell us how well we did that. If we can restore more blood flow to the brain, our patients will do better. And so we strive to get a full restoration of blood flow as often as we can. Of course, when we do an intervention going up into the brain's blood vessels, there are risks, and we need to know about those. We need to discuss those with the patients before we go through this. And one of the risks is causing bleeding. One of the risks is causing spasm or dissection, which is a type of damage to the blood vessel lining. And sometimes those things cause the stroke to be worse than it would otherwise be. But overall, in the balance of the risks and the benefits, this intervention has been shown already to help thousands of patients. That's most of what I had, but the last thing that I just wanted to emphasize is stroke care, and especially the highest level of stroke care, where we do interventions to help people who have major strokes by doing endovascular treatments and medical treatments with clot-busting medications. It takes a whole team of people, and we rely on that here at Washington Health to give you the best outcomes that you could possibly have. So thank you very much. That's all I had prepared, and I would certainly welcome any questions.
Thank you very much. We do have a few questions. From the time a patient reaches the emergency room, how long does it take to determine what course of action a physician will take for the patient?
That's a great question. The first thing to note is that often we have some signs that a patient may be experiencing a large vessel stroke before they even reach the emergency room. So there are certain scales and signs that the EMS technicians are looking at to see if this is someone they need to alert the emergency room beforehand that might be someone who may need some intervention. But once they get to the emergency room, we want to get imaging within 30 minutes to be interpreted and to make a decision about administering a clot-busting medication or going towards an intervention. And we have different goals for how long it can take us to get from coming in the door to getting into the angiographic suite and getting a treatment. And usually we want to do that within 60 minutes. And we want to get reperfusion or restoration of blood flow within 90 minutes. So these are the goals that we set for ourselves and that we try and achieve for every patient.
Is a thrombectomy a new procedure?
Again, it's an interesting question. There have been different techniques to try and do this, probably for the past 20 years. But our equipment has dramatically changed, and since 2015 it's become much more of a standard of care. Nonetheless, there's a large proportion of our population that doesn't have immediate access to this technology, and so we're trying to give it to as many patients as we can.
And the last question we have is, what is the recovery time after a thrombectomy?
So having a thrombectomy entails a small puncture in the leg, in the blood vessel in the leg, which is closed typically with a closure device, a little clamp which shuts off the hole in the blood vessel. And so it's really a minimally invasive procedure. There's not a lot of recovery time from the procedure itself, and our patients get up and work with physical therapy the next day. So it doesn't make a difference to the overall hospitalization. The recovery from the actual procedure takes a couple of days, but the main thing that patients are going through is recovery from the stroke. So they're going through physical therapy, occupational therapy. They may need to go to rehab and speech therapy and things like that. So we're thankful that the actual procedure itself doesn't cause pain or a lot of significant effects. But we are here obviously to check on everything afterwards to make sure that our patients are doing well.
Okay, thank you very much, Dr. Raper, for this insightful presentation, and this does conclude our program. Thank you, viewers, for tuning in. The entire broadcast of today's presentation will be available on our Facebook page and YouTube.